I think what we're hearing, which is always a little frustrating, is that for most people who have some breast cancer risk, for all the reasons we can't predict who exactly gets it, we've heard from Walter that it's hard to prevent breast cancer just by lifestyle. And besides, by the time most of us get around to thinking that this is something we really want to do, we've passed the period where it would have been most useful. And maybe you're better than I am, but I can't get my daughter to eat a low-fat diet thinking about breast cancer down the road. She doesn't think about too much down the road at the moment. Well, some things, but that's, this is life. And what Marc talked about was, I think, among the most important findings in breast cancer, that we actually can reduce risk, and not only can we reduce it by 50% or more, but this year the data shows that the benefits last much longer than the 5 years that someone would take it. 5 years is long enough, but that the benefits can last up to 20 years. So it's an investment of 5 years in a long-term prevention. The problem is that the drugs don't make you feel great. Some people feel fine, but they probably get less benefit. And we need to find better ways to do this. And we also need to be better at figuring out who really needs to put up with the side effects and take this stuff and get the benefits, and who might want to find other, maybe less effective measures, but don't need as much prevention. And that's part of where genetics comes in here, even though, I mean, certainly all of life is not about genetics, but as Marc mentioned, those women who might metabolize the drug differently to get the side effects and the benefits do so because of some minor genetic variations in the genes that metabolize the drug. So someday we might be able to use these genetic tests to help figure out risk and what to do about it all at once. Not yet. Now we have to concentrate a little bit on the group whose risk comes so much before menopause, before the time when taking the medications might be the best approach, or before the time when diseases that are mostly hormonally related will develop. And those are women who, at least at the moment, some of those women we can find with genetic tests. And what we've proven is that there certainly are ways to reduce risk. But again, these are ways that we wouldn't want the general population to be using, and most of them are surgery. So no one wants to recommend prophylactic mastectomies to a young woman, but my patients who have young children and their whole lives ahead of them, all they want to do is avoid what their mother did. They don't want to get breast cancer, and they don't want to die from it. So we have two possibilities here, and we can certainly, in those very high-risk women, tell them that we now have data that we can reduce their risk. But at the same time, what we need are better ways to figure out when, for that specific woman, is that breast cancer likely to come. So can we focus instead on monitoring her more closely, trying to find changes before there's actually cancer, or at least telling her, you don't need to do this now, you can wait 10 years, and in those 10 years, with other interventions, with birth control pills perhaps, or with potentially tamoxifen, we would be better able to reduce or delay those risks so that even if surgery was where they ultimately had to go, it could be later. At least we know it works. When to do it, that's the struggle.
It's very important. A gigantic study was done in which women who had an average risk of being a 56-year-old. So if you were over 56, because your risk goes up as you get older, you were eligible for this study. And if you were under 56, you need to have some other risk factors. And in that study, tamoxifen was given for 5 years versus placebo, and breast cancer was reduced 49%. That's half. That's gigantic. And furthermore, as has already been mentioned, there was a substantial and statistically significant reduction in fractures because tamoxifen actually is quite protective for bones. I helped run a different study in which Evista, or raloxifene, was also used for a different group of women, women who had already been diagnosed as having osteoporosis. And in that study, raloxifene reduced breast cancer incidence 72%. That's gigantic. And then the National Cancer Institute, together with another large cooperative group, did a study which compared the two head-to-head. And they were about equivalent, but raloxifene had slightly fewer side effects, and so it's more or less been declared the winner. So you have a drug that, taken by women over the age of 50, will prevent about half, at least half, of breast cancer, and almost no one does it. It's one of the least prescribed medications.
Well,
for
Mark,
breast
it
cancer.
depends who's doing the prescribing, right? Because
No.
the gynecologists give it for treatment of osteoporosis.
I think I want to be very clear about this, that I often lecture to oncologists, and I often ask for a show of hands, how many of you do this? And the response is paltry. What's interesting is that much of this, in my opinion, very understandably, is driven by women who say, I don't really want to have the side effects. I don't want hot flashes, and I don't like the feeling of being maybe a little bit in the dumps. And what's tragic is that one of the people in my laboratory working with others has recently done a major study showing that it is the very women who have the worst hot flashes who have the most benefit. Isn't that tragic? So these are the women most likely to stop taking the medicine because they don't like it. And the reason they're having the most side effects is because tamoxifen really isn't the drug that works. It has to be metabolized in the body to a more active drug called endoxifen, and some women do it better than others. So if you do it and you make this active metabolite, you have hot flashes and you're getting the benefit. So we need to find drugs that can sort of thread a needle of side effects, but it is incorrect. It is simply incorrect to not say that we have medicines that you can take as a pill that will reduce a woman's risk of breast cancer by 50%.
Right, so this was an impossibility years ago. It was believed to be an outrageous proposition, and in fact, the first study Mark referred to was so controversial that there were groups protesting its existence before it was performed and while it was underway. So there's what we call in science a proof of principle here. And the principle is you can take a pill and you can lower your risk of breast cancer. You can challenge us to come up with an even safer pill. You can challenge us to come up with an easier to take medication. But it is no longer fair to say that you can't prevent breast cancers. Risk reduction is entirely possible. It's entirely possible, to a modest degree in the general public and to a very marked degree in specific groups of people.